Hello everyone. So today we are going to discuss ophthalmology. In ophthalmology, the first thing that we are going to discuss is the structure of any eye station. So in a history of presenting illness, the first thing that you need to ask is you need to ascertain in which eye is the patient talking about. Okay, if the patient says I have pain in eye, you need to ascertain whether it's left eye or right eye. Okay, so which eye is basically symptomatic. The next question will be what about the other eye? So you need to compare the other eye as well. After this, you need to ask about Odipara or Socrates, depending upon the symptom. So the patient is having pain in the eye, then you will ask Socrates. If it's any other symptom, then you will ask Odipara. Then after asking Odipara and Socrates, there are some symptoms, cardinal symptoms of eye disease that you need to ask from each and every patient, just like we had cardinal symptoms of ear disease that we asked each and every patient in ENT. So you will ask about any pain in the eye, any redness, any itching, any discharge. Are you able to see clearly? So visual acuity, any injury to the eye. So trauma to the eye is also very important. And you should also ask, do you wear um, eyeglasses or contact lenses? Because wearing eyeglasses having short-sightedness or long-sightedness is a risk factor for other eye conditions as well. And contact lenses are also risk factors for many eye conditions, including infections. Okay, so these are the important questions basically. And then you will go to the past history. So in past history, you will ask, has this ever happened before in any other medical condition at all? Other medical conditions like high blood pressure, diabetes, they are all important because they can affect the eye. Like for example, hypertensive patient can have hypertensive retinopathy, diabetic patient will have diabetic retinopathy. Okay, obese patient with metabolic syndrome can have central retinal vein occlusion. So other medical conditions are also important. Okay, after this, you will ask about maftosa, which is any medication that you are regularly taking, any allergies. Family history of eye conditions is important in some cases. For example, like in age-related macular degeneration, etc. Glaucoma as well. Okay. Also, the psychosocial history is important. It's really important. You should ascertain what is the impact that this condition is having on the person's life. Okay, is he able to do his daily activities? Is he living alone or does he has any help? Okay, how is it affecting his job? So psychosocial is very important in eye cases. Another important thing that I want you to remember is if the eye condition is affecting the vision. Okay, any eye condition affecting the vision, you should always ask, do you drive? Okay, not all eye condition affect the vision, but in those where the vision is affected, which we will discuss soon, you should always ask, do you drive? Okay, and if the patient is driving, you should advise him not to drive at the moment until their condition is better. And if the vision impairment is kind of permanent, then you will advise them to contact with DVLA and to not drive at the moment because of their safety and others' safety. Examination. In examination, you will do the vitals and GP as usual. After this, you will do the eye examination. So the first thing is naked eye examination, and then visual acuity, visual field, pressure inside the eye, which is basically which we usually perform in cases of glaucoma only, and fundoscopy. So we'll tell the patient, I will look at the back of your eye. So these are the examinations in ophthalmology station. Okay. So in ophthalmology, basically the two major symptoms are red eye and loss of vision. Okay, I want you to remember the differentials of these two major symptoms for plab 2, and that will pretty much cover your entire ophthalmology um, because they really cover a lot of diseases or most of the diseases. So red eye, let's talk about red eye first. So we can classify red eye again into two groups, with defective vision and pain and without defective vision. Okay. So if the patient is having red eye, we can classify this symptom into two groups. One is defective vision and the other is without defective vision. Those with defective vision also cause pain. Okay. So under this group, we have acute angle closure glaucoma, which presents with, as you all know, pain, defective vision, and red eye. But in acute angle closure glaucoma, the most predominant symptom will be pain. Okay, the patient will present with pain. The patient will not present complaining of, doctor, my eye is red, because in glaucoma, the pain is really, really severe. We'll talk about this in a minute. But the most logical classification of these diseases is to group them under the symptom of red eye. Okay. We will discuss each differential one by one. Don't worry about dates. The first one is acute angle closure glaucoma. The second is acute uveitis. The third one is keratitis. Fourth one is endophthalmitis. And fifth one is trauma to the eye. Okay, so we have 5 diseases here in which there is red eye with impaired vision and pain. Okay, then we have patients presenting with red eye without defective vision. Okay, so they have no visual impairment. But they can be further classified into two. Those who do not have any pain, there might be some discomfort, feeling of grittiness, itchiness, but no pain. So these include conjunctivitis, episcleritis, and subconjunctival hemorrhage. So these 3 are patients with red eye, but no pain and no impairment of vision. Conjunctivitis, episcleritis, and subconjunctival hemorrhage. These are kind of the mild diseases, and all of them are severe. Okay, then we have patients with red eye without any visual impairment but with pain, and this include only one disease, which is scleritis. Okay, so let's discuss the first group, patient with red eye with defective vision and pain. The first differential here is acute angle closure glaucoma. And acute angle closure glaucoma, the patient is in a lot of pain, crazy amount of pain, so much so the patient is vomiting. Okay, and this patient presents to the ER. All right, there is impairment of vision due to haziness of cornea. Okay, so what happens basically in acute angle closure glaucoma is there is impairment of circulation of the aqueous humor. Okay, because in these patients the interior chamber is really shallow and the angle is blocked, so the pressure inside the eye rises. There is no drainage of aqueous humor and the pressure inside the eye rises. Okay, this leads to 2 things. The first thing is haziness of cornea. Okay, cornea become edematous. So when the cornea become edematous, it's not clear as normal. It become kind of hazy, and the patient is not able to see properly. This is the impairment of vision in like which presents acutely. Okay, but if the pressure is relieved in these patients, if they go to the ER quickly and that they are treated quickly, then what happened is corneal edema, it's kind of temporary and it reverses back and the patient is able to see normally, and the visual impairment is like there is either no visual impairment or the visual impairment is really minimal. But if these patients, if their presentation or treatment is delayed, then the chronically, like the IOP, if it's elevated for a long time, 10 hours, 12 hours, then it ultimately damages the sensitive fibers of the optic nerve. So when the optic nerve fibers are damaged, then in that case, the visual loss, the vision that is lost is more and it's permanent as well. Okay, so I want you to remember this. Okay, so patient is in a crazy amount of pain. He's vomiting, his vision is impaired, and the cornea is edematous. And the one thing that is really specific to glaucoma is there are colored halos around light. So patient says that I can see colored rings, colored halos around light. There may be risk factors in the history like hypermetropia. The patient may say, Doctor, I'm long-sighted. Okay. So, what will you do in examination? You will do the vitals and you will examine the eye. So an eye and naked eye examination will be congested. It will be red. Cornea will be hazy. When you will do the visual acuity will be reduced. And you will also tell the patient that you will measure pressure inside your eye with a probe. The pressure is going to be really high, like 50 to 80 millimeter of mercury. So please keep in mind that IOP you can only measure in the emergency department and in the ophthalmology department. You cannot measure IOP in the GP setting. There are no means for measuring IOP in the GP setting, the intraocular pressure. Okay, how are you going to explain it to the patient? So you will tell the patient that the pressure of fluid inside your eye has increased quickly due to blockage in the circulation of the fluid. This is called glaucoma. It is an emergency because it can unfortunately cause permanent damage to the vision if not treated promptly. So the patient asks why. You will tell them that people who are at risk of developing, people who develop glaucoma have some risk factors like small eyeballs or they might have long-sightedness. Okay. So whatever is the case, if the patient has a family history, so you can tell that some people have smaller eyeballs than normal population and they're at risk of getting glaucoma. As your case, you have a family history, and then if the patient is long-sighted, then you can tell them that in your case, the risk factor is long-sightedness. Treatment, so basically, we'll tell the patient that we are going to admit you today. I'm going to inform my seniors. We'll give you some eye drops to reduce the pressure in your eye. Okay, so first thing is admission and informing senior and giving eye drops to reduce the pressure. We will keep giving the eye drops every 15 minutes until the pressure is normal. Okay, in addition to that, we'll give you some medication through your vein to reduce the pressure in your eye quickly, and we will keep examining you repeatedly. You will also tell them that we will take the eye doctors on board. So it is like ophthalmology referral, but if the patient is in the ER, so it is internal referral. So they will just inform the ophthalmology department, and someone from the eye department will come and examine the patient in the A&E, and later might shift them to the ophthalmology ward. Okay, so we'll tell them that we will also take the eye doctors on board, and as soon as the pressure is normal, you will have laser treatment to open up the blockage in fluid circulation. Okay, so basically the laser iridotomy, you will tell them about it. And we'll also tell them that the other eye will need the same laser treatment, because in case of glaucoma, when we have acute angle closure glaucoma taken the one eye, we also do laser iridotomy in the other eye for primary prevention. Okay, we will safety net them about driving, of course. Acute uveitis. So the first group that I talked to you about, the patient with red eye with defective vision and pain, I told you about 5 diseases, okay? But the most important here is glaucoma, okay, and acute uveitis. So acute uveitis, patient present with redness, pain, and watery discharge. Pain in acute uveitis is kind of one step less than the acute angle closure glaucoma, but these patients also have considerable amount of pain. There is watery discharge, there is blurring of vision, and there is something that we call as glare. Okay, glare is there in acute uveitis as well. It's there in cataract as well. So glare is increased sensitivity to light, basically. So patient will tell you that lights appear brighter than normal to me. Okay, I cannot tolerate looking at lights. In case of acute uveitis, the patient will have recurrent episodes. So recurrent episodes, there is history of recurrent episodes and systemic symptoms, because acute uveitis is usually related to some underlying disease, like for example, ankylosing spondylitis, rheumatoid arthritis, and things like that. So you will ask about systemic symptoms like back pain, joint pain, oral ulcer. So autoimmune disease and acute uveitis, they have very strong correlation. So you might find these points in the history. There will be history of recurrent episodes. And when you examine the eye, you will find that the eye is red, and there's something which is we call as hypopion. There is pus in the interior chamber, and there is irregular shape of pupil. So basically, as you all know, that acute uveitis is basically inflammation of the uveal tract. That is basically the iris. So what happened is you have, let me show you the picture. So something like this. So the eye is red and congested, and the pupil, if you can see, is irregular because iris is inflamed, and it sticks posteriorly to the lens, so the pupil become irregular. Okay, and sometimes you can see pus level here, which we call as pus in the interior chamber or hypopion. Okay, so this is what you might find on examination. Okay, now let's discuss the management. So first of all, we are going to explain it to the patient that you have inflammation of the middle layer of the eye, and this is called as uveitis. What we are going to do, we are going to give them pain relief and steroid eye drops to control the inflammation, because mostly it is because of autoimmune disease. So steroid eye drops will help. And whatever the underlying disease is, whether it is rheumatoid arthritis, whether it is ankylosing spondylitis, whatever you may find in the history, the patient might already be a diagnosed patient of these diseases. So you will refer them to rheumatologist to control the underlying disease. Okay. Endophthalmitis. Endophthalmitis is another very serious condition. I am discussing this just for the sake of completion. Okay. So the patient present with pain, redness, and defective vision. All right. But in cases of endophthalmitis, the patient have recent intraocular surgery history or history of eye trauma. So endophthalmitis is basically infection of the eyeball, and it's really, really severe. Okay. And the patient can, they can be permanently blind after this. So in these patients, the clue is recent intraocular surgery or eye trauma. How much recent? So like within a day or two or three. Like so the within the last 3 days he had a ocular surgery, okay? Not like 3 months or 2 months, okay? It must be very acute. And after the surgery or trauma, the patient is having pain, redness, and defective vision. There's a patient is in a lot of pain. There might be fever. The patient will say, I have pain on moving the eye, and there is marked impairment of vision. Examination will show redness, corneal edema, pus in the anterior chamber. Of course, visual acuity will be reduced. So we will explain it to the patient that you have an inflammation of the internal layer of the eyeball, and this is called as endophthalmitis. Okay, and the management here will be admitting. Basically, if it's present in the GP, then we will refer immediately to the hospital. But if it present in the ER, then we will admit the patient, and we will give them we'll take some swabs from the eye, and we'll also take some intraocular fluid, okay, from the eye, and we'll send to the lab. Blood testing, routine blood test, blood cultures, etc. And after that, we will give them antibiotic eye drops, pain relief medications, antibiotic eye drops, and antibiotics through the vein. Okay, so that is basically the treatment of endophthalmitis. This was basically the management of endophthalmitis. Now we will discuss another differential, which is keratitis. So keratitis is basically inflammation of the cornea. And as the cornea is affected, it results in pain because the cornea has a really rich nerve supply, so it results in significant pain. Okay, the eye is red because of the inflammation, and as the cornea is affected, and the cornea is the clear layer of the eyes, there is visual impairment or defective vision. Again, because cornea is really sensitive, we feel foreign body sensation all the time. In patients with keratitis, they complain of something called as grittiness, which is sensation of foreign body, and glare. Okay, so glare is there in acute uveitis, and it's there in keratitis, and it's basically the feeling of increased photosensitivity. Okay, in keratitis there will be history of contact lens wear, okay, with history of swimming or contamination. All right, so there might be like the patient might be wearing contact lenses, and they might not be taking good care of their contact lenses. They might not be cleaning them with contact lens solution. There might be some history of contamination of the contact lens solution. There may be history of swimming wearing contact lenses. So these patients will have history of wearing contact lenses, which has resulted in infection of the cornea, or they may have history of trauma to the cornea, or they may be diabetic or immunosuppressed. In those patients, viral keratitis is also common. So you might find these points in the history. And during management, you will explain it to them that it is an infection of the cornea, which is a clear window of the front of the eye, clear window of the front of the eye, and this can be very painful. So as it is really painful, we'll give them pain relief, and it's mostly because of infection. So we will give them antibiotic eye drops and steroid eye drops. Okay. So these cases like keratitis and endophthalmitis, I discussed them for the sake of completion. So you have this whole picture in your mind and you can rule out other diseases. The really most important differential diagnosis here is acute angle closure glaucoma. And the rest I discussed for completion's sake, but please keep these in mind as well, because really anything can come up, and you should also be able to rule them out during history taking. Okay. So now let's discuss the differentials of red eye without visual impairment. So let's first discuss the cases where there is no pain. So basically conjunctivitis. Conjunctivitis, as you all know, is inflammation of the conjunctiva, and it's really common as well. It can be either viral, bacterial, or allergic. So the patient has red eye, or maybe the redness is really mild. So it's also called as pink eye in those cases. There is itching, discomfort in the eye. The eyelashes are sticky in the morning, and there is discharge. Okay, so basically this is discharge. This is misprinted. So discharge can be watery or purulent. So it's usually watery in cases of allergic conjunctivitis or viral conjunctivitis. Okay, viral conjunctivitis is the one that occurs with common cold. There is watering of the eye. So allergic or viral conjunctivitis will have watery discharge. And in case of bacterial conjunctivitis, we will have purulent discharge. So purulent discharge means bacterial conjunctivitis, and mostly the bacteria are either chlamydia or gonorrhea. And these are basically sexually transmitted infections. So if you have conjunctivitis with purulent discharge, sexual history is really very important. Even chlamydia and gonorrhea, when pregnant female have these, they might, like if they have sexually transmitted chlamydia or gonorrhea, either cervicitis or endometritis, then during birth they can transfer it to the baby, and the baby will have conjunctivitis at birth, which is called as ophthalmia neonatorum. So in that case, you should take the full history from the mother, full history of PID, any discharge, full sexual history, and you should provide treatment to the mother as well. You should refer her to the genitourinary medicine clinic, and treatment for the father as well, because treating partner is also necessary. Okay, so that was another point. Okay, now how will you explain it to the patient? So you'll tell the patient it is an inflammation of the outer thin layer of the eye, which is called as conjunctiva. Okay, so it is inflammation of the outer thin layer of the eye, and it is known as conjunctivitis. It can be caused by either allergies, okay, or it can be caused by infection by bacteria or viruses. So if this is allergic conjunctivitis, if it is because of allergies, then the patient will have seasonal history. They will tell you that they get this allergic conjunctivitis, these symptoms like every season, every summer or every spring. So in that case, they might be allergic to pollen, or they can say, I get this when I am exposed to dust. So in these patients, we will give them antihistamine eye drops, which is basically the treatment of allergic conjunctivitis, and we will tell them to avoid triggers. For viral, we will just give them general advice. I will discuss general advice in a minute, because viral conjunctivitis are basically self-limiting and they occur with common cold. Okay. Bacterial conjunctivitis is a bit more serious, so you will take swabs and you'll send them for culture, and you will give them antibiotic eye drops. Okay. So what is the general advice for these patients? We'll tell them that there are some things that you can do to resolve these symptoms quickly. So what you can do, you should boil water and let it cool down, and then you should dip clean cotton wool pad in it to clean your eyes with it. Okay, and you should use separate cotton wool pad for each eye. Okay, so don't take a single cotton wool pad and clean both eyes with it. So cleaning of the eye basically, and cold compresses, these basically resolve the conjunctivitis quickly. So you should also tell the patient that hold a cold flannel or a cold clean cloth over your eyes for a few minutes, and that will basically give you relief and will resolve the condition quickly. There are some do's and don'ts. So we'll tell them, don't wear contact lenses until your eyes are better. Okay, don't share towels or pillows with anyone. Don't rub your eyes. All right. So you should tell them, wash your hands regularly with soap and water, cover your mouth and face while sneezing, and put the tissue in a bin, especially in case of viral conjunctivitis where the patient is also having common cold. Basically, no need to avoid work or school, just avoid sharing towels and pillows, and wash your hands regularly. No need to avoid work or school. Then episcleritis. So this picture here basically is for episcleritis. So in episcleritis, as you can see here, the inflammation is the redness of the eye is really confined to a particular place, like it's not all over the eye, this is called a sectoral redness. That is, the redness is really in a sector, and sometimes you can see a nodule over the redness as well. Okay, so episcleritis, as it is clear from the name, it is an inflammation of the sclera. So episcleritis, it is the inflammation of the sclera. It is recurrent, okay, and the redness is sectoral, as I already showed you. There is some nodule over the redness. There is no pain. There is some discomfort only, okay. It's basically a self-limiting disease. You don't need to do anything about it. But if the patient is really concerned, then you can give steroid drops. But otherwise, it will resolve spontaneously. It will present to the GP and you don't need to refer. Okay, then we have subconjunctival hemorrhage. So subconjunctival hemorrhage can appear scary to the patient. There can be history of trauma. Okay, it can be because of straining a lot, coughing, constipation, there can be a history of bleeding disorder, or the patient might be on blood thinning medication. So you should like ask all of them in the history. Can be because of aggressive rubbing or high blood pressure. Subconjunctival hemorrhage basically occur when there is a rupture of a small blood vessel on the surface of conjunctiva. So we'll tell the patient that it is a small bleed from one of the minor blood vessel on the surface of the eye. So it's kind of like a bruise. You will tell the patient it's kind of like a bruise, but it's on the surface of the eye. I think I put a picture of it somewhere here. No, there's no picture of it. Okay, so a small blood vessel, you'll tell the patient when a small blood vessel or one of the minor blood vessel rupture on the surface of the eye, there is this small bleed, and it is called a subconjunctival hemorrhage. You don't have to worry about it. It will heal on its own, but usually takes 2 to 3 weeks. Okay. And during this time, when it is healing, you will notice a yellow tinge to your eye during this time. The patient doesn't need to do anything about it, but if feeling any gritty sensation, then give lubricating eye drops. And the last condition here is scleritis, which is patient with red eye without visual impairment, but with pain. Okay, so this is the only disease in that group, which is scleritis. Now, scleritis patient will have severe pain. So scleritis patient will scream. I want you to remember this, okay? Like episcleritis, the redness can be sectoral, okay? Like here, you know, the whole eye is not red, but a portion of it. So it can be sectoral, or it can be complete. And these patients, they have severe pain. The vision is not affected. There can be some a little bit watery discharge. Basically, these patients will have systemic involvement in 50% of the cases. 50% of these patients will have an underlying disease. Okay. Now, the disease can be any autoimmune disease like rheumatoid arthritis. Okay. It can be infectious disease like SLE. So there is an underlying disease in 50% of these patients. Okay, so how will you explain it to the patient? You will tell the patient that it is inflammation of the sclera, which is an outer tough white layer covering the eye. Okay. Now, episcleritis, as we discussed, was basically, it was related to autoimmune diseases, but it was basically, there was no pain and there was only redness. And we told the patient that it will resolve on its own, but if the patient was really concerned or there was some discomfort, then we gave steroid eye drops and there was no need to refer. Scleritis is completely different. Scleritis is an emergency, okay? So you'll give the pain relief. If this patient present in GP, you will only give pain relief and you will refer them to the ophthalmologist. Emergency referral to ophthalmologist within 24 hours. So basically same day assessment by the ophthalmologist. What the ophthalmologist will do? They will investigate for the underlying diseases because 50% of them have some underlying disease. They will do investigation like full blood count, ESR, CRP, NTCCP for rheumatoid arthritis, syphilis screen for syphilis, autoimmune screening for other autoimmune disease. They will give painkillers, steroid eye drops, and they might need to give systemic immunosuppression, okay? And might require a co-referral to rheumatologist to control the underlying disease. So that was all about scleritis. Remember that episcleritis is self-limiting, but scleritis is an emergency referral. That was all about red eye. And I hope it was helpful. I will see you soon with the next video in ophthalmology series, which is loss of vision.